I'll be talking about intravascular ultrasound in calcified lesions. Now, what is the role of imaging in calcified lesions? We can divide it into 3 steps. One is pre-stent assessment, intra-procedural guidance, and what is the role in post-procedural optimization. Let us see how this makes a difference. We are all familiar with this calcium score, which has been displayed in most of the conferences. But if you see the algorithm, it all starts with whether there is angiographic calcium or not. And the answer is yes. Then the next question is whether the IVUS is showing a calcium arc of more than 270 degrees. So the relevance of further scoring comes only after when the answer to these 2 questions are yes. So fluoroscopy is very important, and your approach to calcified lesions start with good fluoroscopic analysis. Here you can see when we take the RCA angiogram, the calcified outline of left system is already seen. And if you have a calcium that is seen on both borders of the vessel wall, and if it is seen in the still frame, then it signifies severe calcium. So some studies have shown that it is not only the target calcium that is important, the calcium along the stent delivery route is also equally important, and it impacts the restenosis rate. And if you have severe calcium in fluoroscopy, it generally correlates with severe calcium in imaging. You can see here, if you have severe calcium on angiogram or fluoroscopy, generally the arc of calcium is more than 3/4. On the contrary, if you don't have fluoroscopic calcium, and even if your IVUS angle is more than 180 degrees, it generally have a thin calcium, and you may not need the lesion preparation before the stent placement, and stent areas are very good. So fluoroscopic calcium indicates moderate or severe calcium. It indicates superficial calcium and wider arc of calcium. So good fluoroscopic analysis is very important before approach with the imaging. So pre-stent assessment, you look for these attributes on intravascular ultrasound: location, arc, length, and whether there is any calcified protrusion. So this is an example of a superficial calcium. When you have calcium that is within the 50% from the further 50% from the lumen, and deep calcium when it is more towards the adventitia. Now, what is the importance? Superficial calcium is the one which impacts the stent delivery and also stent expansion. And most of your atherectomy devices are directed towards superficial calcium. Deep calcium generally doesn't interfere with stent expansion, but when it is extensive, if it is occupying more than 3 quadrants and associated with a superficial calcium, then probably you may have to modify with special devices. This is a 54-year-old gentleman who had a trope posterior anterior bandha. You can see he has a calcified ostial lesion of the obtuse margin. And when this is what intravascular imaging showed. You have calcium on one half of your imaging screen. And here is another case who have more than 3 quadrants calcium. So more than 3 quadrant calcium and 360-degree calcium should be distinguished, because even if you have one small quadrant where you can see the vessel wall beyond the calcified plate, then you can imminently expand it with special devices and balloons. But if you have perfect 360-degree calcium, this is a very important determinant of stent expansion, and you may need special devices like cutting balloons, scoring balloons, or IVL, or other devices to modify it. So distinguishing the perfect concentric calcium from more than 3 quadrant calcium is very important. So only calcium arc of more than 270 degrees will impact stent expansion, and 360-degree calcium is a very important predictor of stent expansion. And mostly when you are using a longitudinal view, if you have a long length of calcium that is more than 5 millimeters, especially if the calcium arc is more than 270 degrees, this is also an example where the stent can get underexpanded without optimal lesion preparation. This is a 76-year-old gentleman, critical lesion at the obtuse marginal origin. And when we took the imaging, you can see there is a nodular protrusion. This is another expression of calcified lesions, a nodular protrusion. And most importantly, the IVUS catheter seems to hug the nodule. So this is an example where the term refers to as favorable catheter bias. This is another patient who had a class 3 effort angina, and when you see that there is another nodular protrusion, but the IVUS catheter seems to be away from the nodule, which is just touching the tip of that nodule. So this is an example of an unfavorable catheter bias. I will come to that. This is another expression of calcium. This is a patient who has out of hospital cardiac arrest, ST elevation 2-3 AVF, and when you see the calcium, the surface of the calcium has irregularities. So this is an example of an eruptive nodule. Calcified nodular protrusions are actually part of calcified atherosclerosis. But eruptive nodules, there is disruption of the calcified plate, protrusion of the fibrous tissue, and deposition of platelets. So eruptive nodules are a very important cause of ACS and sudden cardiac arrest. And eruptive nodules can be easily deformed with a non-compliant balloon. But nodular protrusions may need special atherectomy procedures. So that's the importance of identifying the different attributes of calcium. So in a pre-stent assessment, you look for 4 attributes: arc of calcium, location, length, and nodular protrusion. If you have nodular protrusion, look whether there is any favorable catheter bias or not. Now, after the lesion preparation, you should always perform as IVUS pullback to verify your success. This is the case which I had demonstrated a couple of slides earlier. We dilated the scoring balloon, and you can see there is lumen enlargement and calcium fractures at 3 and 9 o'clock position, signifying calcium preparation. This 82-year-old gentleman who underwent rotablation, and after rotablation, you can see reverberations. Reverberations signify that the calcium has been polished, and this is amenable for further dilatation with balloons, non-compliant balloons. And in the case which I had shown a favorable catheter bias, I performed a rotablation, and you can see the nodule has been shaved off. And it is better, I appreciate it in the longitudinal view where the nodule appears to be disrupted. And this, in the other case where there was no favorable catheter bias, we used orbital atherectomy, and the nodule is shaved off, and there is reverberation artifact. So this is how you confirm your success of lesion preparation. And what do you look for in the post-stent assessment? As in any other case, this figure applies to calcified lesions as well. There should be good expansion, there should not be edge dissection, there should be extensive malapposition. But there are certain peculiarities of which one operator should expect when you are deploying stent in a calcified lesion. This is a patient who are present with a non-culprit lesion to LAD which was highly calcified. You can see in the intravascular ultrasound there is a concentric, concentric calcium, and there is nodular protrusions. We deployed 2 stents, and you should expect these type of stent expansions. C-shaped, D-shaped, eccentric expansions. But what this matter is just what minimal stent areas you have achieved. In the top panel, you can see the minimal stent achieved as not optimal, and the lower panel, even though the shape appears to be something abnormal, the minimal stent area was 1.23 millimeters square. And also, you should expect some degrees of malappositions, especially at the shoulder of the nodular protrusions. If you try to achieve a circularity of the stent, then you may land in trouble. So primary goal in post-stent assessment is to achieve an optimal minimal stent areas. Eccentric expansion is very common, and minor degrees of malapposition may be accepted at the shoulders of calcified nodules. And we should not chase any circularity of stent, always chase optimal MSS. This is an example, a 64-year-old lady who presented with a stent thrombosis about 6 months later, and the reference area was 11.42, but in the mid portion of stent, you can see stent was it's underexpanded, and the minimum stent area achieved was finally 5.25. The operator has not recognized it. But luckily, we could redeploy it with a non-compliant balloon with the high pressures. Always, it may not be the story in any cases. So, IVUS evaluation of calcium can be summarized into assessment run, lesion preparation run, and post-stent run. In the assessment run, you look for location, arc, and protrusion. Lesion preparation, look for calcium fractures, lumen enlargement, reverberations, and post-stent, look for minimal stent areas. So, in short, an approach to calcified lesions starts with thorough analysis of fluoroscopy. Each attribute of calcium must be considered. It is easier to modify the calcium before rather than placement of the stent. Don't try to expand the lesion with your stent. Always expand with your balloon and atherectomy devices. And once you achieve a very good lesion preparation, the final procedure should be the stent placement. And the degree of stent expansion and clinical outcomes are directly proportional to optimal lesion preparation. I'll be happy to take any questions. Thank you.
When you talk about eruptive nodular calcium, the fact that I didn't hear, maybe I missed it, it comes back very often, and we don't know why. What do you suggest as a treatment, and do you encounter that a lot?
As you rightly point out, eruptive nodules can be easily deformed with a balloon, and we can stent it, we can achieve very good result on table, but most often it comes back because of the biological nature, because eruptive nodules are biologically active. Probably the answer to that question is optimal medical management. We have to really target the cholesterol levels very lower. We have to modify the medical management. But intervention management, I'm not very sure whether intervention management prevents the growth of eruptive nodules, because these are biologically active nodules.
And my other question is about the artifact. You didn't mention the spasm. Do you consider that as an artifact? Because a couple of people have put a stent when there was no need to put a stent. So do you consider that as an artifact?
Very good point. In fact, it's a biological phenomenon, not an artifact, but people should be cognizant of this. And because it's not something which is based on the sound properties and all. Yes, many times it is due to catheter tip, guide tip, the RCA, ostia gets spasm, goes into spasm, and many times people mistakenly put a stent there. So it's not I will not label them, categorize them in the artifact, but yes, it's a phenomenon which people, interventionists, imagers should know about it and should not put a stent. A very good point for the fellows.
One question to Dr. Sajan. How important is to determine the thickness of calcium? Because IVUS cannot determine thickness. How important is when you deal with these calcified lesions?
Yeah, because that's one drawback of the intravascular ultrasound, because intravascular ultrasound cannot penetrate calcium. The thickness is an attribute that is can be assessed only with OCT. And it has been shown that if the thickness is more than once the thickness crosses 500 microns, that the curve actually, the chance of stent under expansion actually increases. And some studies have shown that the success of
Did you find any in some cases, did you feel the need for assessing thickness when you did an IVUS? Just suppose thickness, had I been known the thickness, I would have changed my strategy. Did you felt any time in your practice that because IVUS, once you do the IVUS, thickness is not determined?
Yeah, actually,
you switch over to OCT to find the thickness.
Yeah, actually, see, if you compare both the imaging modalities, see, if you are following one imaging modality like intravascular ultrasound, probably you cannot complain on that because your imaging modality is not going to give you that information. But you have to go by the other parameters, which I have already discussed. Of course, if you had another evidence of, if you have another method of assessing calcium, thickness of calcium, well and good. But if it's intravascular ultrasound, the operator should be trained enough to go by the parameters which I have discussed and then modify the lesions accordingly.
Only indirect parameters are useful between the thin plate and thick plate of superficial calcium, depending on the equivalent space behind it. That is important, actually, beautifully shown the images. Okay.
Dr. Sajan, how important is you to determine the calcium scoring? Do you do in your clinical practice the calcium scoring to assess the need for atherectomy?
Yeah, I actually do calcium score when I see severe calcium on the angiogram, because when the fluoroscopy, that's why I started my talk with the good need for assessment by fluoroscopic image. Because if you see the fluoroscopy showing calcium on both borders of vessel, and if that calcium is visible when the still frame, then you are dealing with the severe calcium on the imaging mostly. So those cases where I have trained my technicians also to perform calcium score. If the calcium score is very high, then probably my threshold of using atherectomy procedures is very high.